everyone. Today we will be discussing the historical aspects of the rabies disease. More specifically, we will be talking about how the rabies vaccine, developed by Louis Pasteur, developed over time to make an impact not only historically, but also scientifically, socially, and ethically. First, we will be discussing the etiology and epidemiology of rabies, followed by the development of the rabies vaccine by Louis Pasteur. Next, we will focus on how the vaccine has changed over time and the current vaccine that is in use today. Then, we will discuss how the vaccine has impacted different populations. In conclusion, we will address possible strategies to reach eradication of rabies.
Rabies is a zoonotic disease that is commonly transmitted through bites or scratches of rabid animals. More specifically, rabies infects the central nervous system and leads to disease of the brain and in many cases death. The early symptoms of rabies in people are similar to that of many other illnesses, including irritability, fatigue, malaise, nonspecific distress, and without treatment, later symptoms include inflammation of the brain, slight or partial paralysis, difficulty breathing, severe chest or stomach pain, hallucinations, and hydrophobia. Coma and death, usually by respiratory failure, occur within 7 to 10 days after the first symptom is observed if no intensive care is instituted.
Louis Pasteur, commonly known as the father of microbiology, is credited with the development of the first rabies vaccine. Pasteur produced the first vaccine for rabies by growing the virus in rabbits, and then weakening it by drying the affected nerve tissues. In 1885, the vaccine was first used on a 9-year-old Joseph Meister, and it proved to be successful. Louis Pasteur's work was scientifically impactful as it advanced the field of vaccine research all across the globe.
While Pasteur's vaccine was successful in treating rabies, the source of the vaccine, nerve tissue, triggered allergic reactions in some cases, including autoimmune encephalomyelitis. Since the development of Pasteur's vaccine, the struggle to find a safe and effective vaccine against rabies has taken more than 100 years. In 1911, David Semple, a British researcher in India, used phenol to more reliably deactivate the virus. In addition to the rabbit nervous tissue, Semple also used virus-infected goat and sheep brain tissue. This new rabies vaccine was termed the Semple-type vaccine. It was the most commonly used rabies vaccine in the world until vaccines became available that were produced using duck embryos. In 1947, Hilary Kaprowski created a rabies vaccine from non-nervous tissue. More specifically, he adapted a rabies virus strain in chick embryos. He hoped to avoid using the nervous system because vaccines containing nervous tissue could cause serious side effects such as encephalitis. In his laboratory, Dr. Kaprowski passed his virus strain through chick embryos 180 times. Because of this, the virus lost its ability to sicken small animals. Kaprowski introduced this strain, which he called HEP, high egg passage, but he continued to work on new rabies vaccine. In 1971, Hilary Kaprowski yet again created a new inactivated vaccine. Dr. Kaprowski and his team of scientists at the Wistar Institute in Philadelphia wanted to improve on the antibody response created by the experimental HEP live virus vaccines. They looked at using a cell line from human embryonic cells to cultivate the rabies virus. However, there was strong opposition to using a live virus. Kaprowski's team then used a chemical to inactivate the rabies vaccine virus. In 1971, Kaprowski also inoculated himself with his experimental rabies vaccine. In 1980, the rabies vaccine produced at the Wistar Institute, called HDCV human diploid cell vaccine, was licensed in Europe in 1976 and in the United States in 1980. One of its principal advantages was that the vaccine was given in 5 injections rather than 14 to 21 injections used in the older vaccines.
The current vaccine that is most commonly used is the HDCV vaccine. Rabies vaccine is unique in that it is most often used after post-exposure. Post-exposure prophylaxis includes a treatment round of the vaccine coupled with rabies immunoglobulin and is given to prevent the progression of the fatal disease. A total of 4 shots are given intramuscularly. The first shot is given immediately after exposure, then again 3 days later, 7 days later, and 14 days later. The only people who typically get vaccinated as a preventative measure or pre-exposure prophylaxis are those who are at high risk for exposure, such as laboratory workers, veterinarians, and travelers going to high-risk countries. For these people, 3 doses of the vaccine are given. The second is given 7 days later, and the third given 21 to 28 days later. Rabies is a disease that exists globally. However, it is endemic, meaning constantly present in the population in most African and Asian countries. While the disease still poses a risk to most populations, developed countries are well equipped financially to afford the burden of this disease, while underdeveloped countries continue to struggle to gain access and affordability to rabies treatment and prevention, ultimately creating an ethical dilemma. According to the CDC, the number of rabies-related human deaths in the United States has declined from more than 100 annually to 1 or 2 deaths per year. Modern-day prophylaxis has proven 100% successful in the United States. The success in controlling this disease is a direct result of animal control and vaccination programs, successful outreach programs, and the availability of modern rabies biologics. While populations in the U.S. are still technically at risk to the disease, treatment is accessible and affordable through insurance to most of the population. Although the U.S. has been successful with combating rabies, the disease remains a threat to half the world's population and kills more than 50,000 people each year, most of which are children. And more than 95% of human rabies cases occur in Africa and Asia. Because the majority of the countries in Africa and Asia are of lower socioeconomic status, they have yet to develop a cohesive and consistent vaccination plan to lower the cases of human rabies. An economic burden these countries face is the increased demand for post-exposure prophylaxis. According to a study done in 2006, the total cost of post-exposure prophylaxis accounts for 5.8% of the annual per capita gross national income in Africa, which equates to $40 per treatment, and 3.9% of annual per capita gross national income in Asia, which equals $49 per treatment. In addition, dog-mediated human rabies disproportionately affects the poor rural communities, particularly in Africa and Asia. A reason for this is that awareness and access to proper treatment is either limited, expensive, or non-existent. Researchers have attributed this increase in rabies to the rapidly growing dog populations. African and Asian nations have attempted to combat rabies through the simple reduction of the dog population. However, the dog populations are underestimated and reduction can be quite counterproductive. In actuality, according to the World Health Organization, the true burden of disease is underestimated due to the lack of reporting and the political neglect of the Asian and African countries.
As stated by the World Health Organization, rabies is 100% vaccine preventable, meaning that by vaccinating the source of rabies, animals such as dogs, transmission will be eliminated and thus the human vaccine will no longer be necessary. The goal of the World Health Organization is 0 deaths by rabies by 2030 through the implementation of mass dog vaccination. One way to prevent the incidence of rabies in lower socioeconomic countries is through mass dog vaccination. According to the World Health Organization, at least 70% of the dog population in the world must be vaccinated in order to break the cycle from transmission of dogs to humans. Both Europe and North America have been successful with the control of canine rabies by coupling the mass vaccination of dogs with the removal of unvaccinated dogs and movement restrictions. While mass dog vaccination has proven successful, it is not necessarily feasible to all populations. This has posed a societal impact on many populations, as accessibility and affordability prevent many populations to follow through with this technique. One way to aid in the feasibility of mass dog vaccination is through a One Health approach. Eliminating canine rabies as a public health burden will require a One Health approach. Human health has been proven to be connected to the health of animals and our shared environment. According to the CDC, a One Health approach encourages collaborative efforts of many experts working across human, animal, and environmental health to improve the health of people and animals. An example of a successful One Health intervention to eliminating rabies is the establishment of an effective collaboration between the medical and veterinary sectors in Kenya. Through this approach of effective multi-sectoral communication, Kenya was able to integrate national plans for rabies control and elimination through mass dog vaccination. Furthermore, countries that are at high risk of rabies should adopt a One Health approach to help facilitate the intervention of mass dog vaccination. The impact of the rabies vaccine started with Louis Pasteur and his historical findings. His vaccine set the stage for scientific advancements not only in the rabies vaccine but also in the field of virology. These advancements led to the current HDCV vaccine and treatment plan. The efficacy of this vaccine has created a positive societal impact towards the eradication of rabies. Although the development of this vaccine has allowed certain populations, such as the U.S., to reduce the number of fatalities from rabies, many developing countries have not been benefited to the same degree. This poses an ethical dilemma in that some populations still struggle with accessibility and affordability of the vaccine, even though the technology exists. The One Health approach, coupled with mass dog vaccination, allows populations to reduce the burden of accessibility and affordability of the human rabies vaccine. Although the rabies vaccine was developed in 1885, it continues to have impacts today.